Welcome to the CoROM Conversations with myself and Bill Vasios. For those of you who don't know Bill Vasios, he's a former 18 Delta, a former bunch of other special forces jobs, and now he's a PA and finishing up his PhD and a fellowship all at once. Um, and we'll walk you through the respiratory. We're walking through the March algorithm. So let me get over to, there we go. So we're basing this off of science, off of CPGs. These are the CPGs list that I've broken down into March pause, which correlates kind of to the college CABCDE. And we're all the way to R now in March. If you want to have a copy of that spreadsheet that I just had with all the CPGs, you can download it here. So on the left is a civilian CABC. Here at the college, we go CABC, D, E, F, G, H, all the way down to H, Hitman, and it forces us to automatically roll over to prolonged field care. On the right is the operational side. Both of them are pretty much, at this point, still equal. So we're talking about breathing problems and respiratory problems. And we've got this from the latest guidelines. So skills. So we're talking about things that we can do to deal with respiratory. And here, according to the TCCC guidelines, the combat paramedic practitioner level can do all of it. So we are going to talk about all of it. So if you want to follow along with a CPG, you can click that and you can download the information where we're getting this from. So Bill came up with this as far as the fourth columns we'll talk about. Bill, I'll let you take over.
Thanks, Aebhric. So by show of hands, clipping the raise your hand in here, how many people are comfortable with the current TC3 guidelines for respiration, the March TC3? Because that was something that Aebhric and I were talking about beforehand, saying, I'm assuming, my assumption is that everybody's going to be familiar with it. If not, then we have slides afterwards to kind of discuss a lot of these things. But if everybody's kind of good in that, then we're just going to do an outline, a concept of some thoughts, right? And I could have put some animation in this and hid a lot of this, but I think as we discuss it, and this should be a back and forth discussion, all right, because we're all going to learn from each other's experiences. We have a lot of experience in this chat, and I think that if we share it, we're all going to kind of raise the level of our understanding, and we'll learn a few new techniques, I think. But my simple approach to a patient concerning respirations is I want to identify, are they just breathing normal? Is this not a respiratory issue? It could be other things. Are they breathing fast? Or are they breathing slow? So the way I usually discuss it is when I assess respirations in a patient is if it's hard for me to detect their breathing, then it's most likely normal, overwhelmingly normal. Because if somebody runs up a couple flights of stairs, they're going to breathe fast. You can notice this. Like none of us here could really tell us how many times we breathed in the last minute because it's just imperceptible. We don't know it. If you were sitting in a room and we were having this conversation across, we could look across and really not tell how many respirations each other is breathing in a minute because it's imperceptible. All right, so those are normal. That generally tells you that it's not a respiratory problem that we're dealing with. If they're breathing fast, then you have to do a little bit of this assessment to determine why. You take in the situation, the mechanism of injuries, anything else that's going on. You take in the environment and understand most of the abnormal breathing that a patient's going to have is going to be fast because of pain, because of exertion, because of physiology or whatever. And kind of open this up at the end. The most obvious reason for somebody to have slow respirations are head injury and drugs. Now, can anybody think of any others? Like, I'm legit question. Anything else besides, TBI and drugs that would cause somebody to have slow respirations?
I think it would come under that same heading with drugs, but I'm thinking some type of a toxin.
Yeah, exposure, envenomation, like snake envenomations, could be a neurotoxic, and they're going to have slow. Yeah, so that's a variation of a medicine, but yeah, absolutely, like how you're thinking. Cool. So now a lot of them. Let's throw out some reasons why they would be breathing fast.
Hypoxemia.
Okay.
Anxiety.
Anxiety. Yes, that's a good one.
Yeah, I missed the slow one, but sometimes when someone's really, really trying to self-peep, I know it doesn't really slow that much, but it won't be fast, but they're just trying to really self-peep, and it takes those really long expiratory phases.
Yeah, like pursing lips.
Mm-hmm.
Yeah, so they're like auto peeping. Great. Good. So as providers, we really want to develop our ability to observe and identify what kind of respiratory issue we're dealing with. If they've got obvious trauma, go with your obvious, but a lot of times they're going to have kit on and they might have a distracting injury, and you may not notice their the change in respirations. So that's something that you really need to hone that sense of how is your patient breathing. An easy way to do that is to talk to them. Somebody that's got a respiratory issue for any reason, really, and they're having difficulty talk because they have to gasp in between, or they have to take a deep breath and then kind of talk on the exhale. Whatever those mechanisms are, that'll help you identify what kind of breathing or respiratory issue that you're dealing with. Any comments or any questions kind of directed at identifying respirations in a patient? All right. So we can break this down into just kind of how do you assess ongoing assessment of normal respirations? Having conversations with them, getting them to tell a little bit about themselves and see if they can talk for longer than a few seconds. Your assessment is going to be an ongoing observation. If they're breathing fast and it's tied to the anxiety that you mentioned earlier, then part of that is calming them down through conversation. So non-pharmacological ways of chilling anxiety, communicating with them, basically saying, do I look upset? Do I look anxious? Do I look worried? Then, match me. If I'm looking worried, then you might want to consider something, but you can do that non-pharmacological way to ease anxiety by being the calm one, and they mimic that. They'll mirror you. That works in the opposite direction too. If you're frantic and you're freaking out, that kind of tends to freak your patients out. So that's something that we as providers need to kind of maintain a good control on. But say you determine that they need some type of intervention. We're over in the treatment colony, assessment and treatment. Just because somebody has a small pneumothorax, do you need to intervene?
No.
Right. That's the obvious answer. So if you can think of a scenario, give me an example that pops into your head where they're breathing fast, they have a pneumothorax. You determine they have a pneumothorax. There's various ways to do that, but say you determine that. What's your over/under for intervening?
If I'm having any deterioration, any hypotension,
based off vital signs.
Say that again.
Is that based off of the vital signs or the mechanism, or the obvious answer is all of the above.
Yeah.
Okay, Lead, you had your hand up for the TC3 question before. Is that still, or do you have a new comment?
Yeah, no, sorry, I just forgot to take it off. Apologies.
Okay, all right, no, that's cool. So there are many cases where we have a change in respirations. They're abnormal. They're too fast or too slow, where our primary treatment is going to be to watch. Right? We're just going to watch and passively observe them, maybe interact with them, but we don't necessarily have to do anything. What I found is the hardest thing in medicine is to do nothing. You get into the checklist of, oh, you're breathing, you're in trauma, I got to do a needle D. You almost go down that checklist. A lot of those training scars occur as a result of how the training is organized. So if you're if you're running training, I mean, we're all somewhat educators by training our colleagues and our non-medic teammates. We need to teach them that it's not just a scenario where, okay, this is a TC3 scenario. We have trauma. You have unilateral rise and fall of the chest. Okay, boom. We're giving them obvious symptoms to intervene, but it's really hard. It's really difficult to train them to just observe and watch a patient over time, to kind of watch those vital signs. And does the anxiety-driven tachypnea resolve itself because you're calm and you drive them to be calm? Do you give them some form of medication to calm their anxiety, realizing that they don't have another reason, a physiological reason to do a invasive procedure? I don't think that we train or discuss that enough when we're doing things. It's very algorithmic. You're in a TC3 scenario, you have this trauma scenario, you get to respirations and you have to do a procedure. I think it's driven because we want people to know how to do the procedures. We want to work through that process. But I think the medical decision-making aspect of that, the part we leave off a lot of the training, is just to watch and observe and passively, you're ready to intervene, but you don't. And that's hard to train. Does anybody have any kind of examples on how to do that, how they've incorporated that into their training or their experience, or maybe been a student and somebody incorporated this?
Sometimes I just actively sit on my hands, and it helps me sort of go through the checklist over and over again.
I think that's a good point. The physical act of sitting on your hands versus the, just controlled and understanding and pause. The three reactions to a situation are fight, flight, and freeze. And so mentally, I don't think we intentionally freeze. Sometimes it happens as a byproduct, but we don't intentionally freeze our process. We want to react and do something.
So I would just say that something that's helped me is deep diving into the pathophysiology of things like tension pneumothorax versus simple pneumothorax, in how long it takes to develop. So from point of injury and mechanism of what's happened to the patient or your casualty, what's the realistic time frame? And it's not a few minutes that it takes to develop. So trying to add the understanding of what is occurring to my patient and how long that's going to take, and trying to teach that in my workplace for people definitely helps to get that key understanding of it's not going to be immediate. It is a consideration, and that's why constant reassessment of your airway and your breathing is so important. But there is a realistic time frame of roughly 40-ish minutes is going to take for that air to entrap. Allows people to think, versus those trainingisms of which I've definitely been exposed to, where it's like, yep, I must see a skill as an instructor, I must tick that off, I will set up my scenario, if that makes sense.
Yes. No, and I think it can happen fast. It really depends on the physiology. Aebhric, if you can jump to slide 17, I think it gives an example, a picture that we can discuss around. Yes. So if you could just have a small injury to the actual lung itself, not just the external chest wall, because I mean you can get a small injury from a rib fracture. You can have a small penetration. You can induce it just by doing a needle decompression on somebody, and that most likely will take a considerable amount of time to build up from a simple pneumothorax to a tension pneumothorax. But if you have significant lung injury and the patient is tachypnic, that progression from simple pneumothorax to tension pneumothorax can be much faster. It really depends on the lung injury, not the outside opening wound. And if that opening is one way, meaning it's only sucking in external air or leaking from the lung. So there's two mechanisms to get air in that free space. If you put in a chest seal, those are designed typically to let air out of the chest but prevent it from going in, right? So I think understanding that and making the assessment of what is the actual mechanism and how severe it is a thing over time. It's not like when you first learn how to do this, that's not a concept that you really can get to. That's a strong leap. But if you've been a provider for a while, you can understand the different ways that tension can develop. So I think it's a good point. So sometimes it's going to take, in training, it happens instantaneous because we make it that way because you sometimes go through a checklist to have them progress. But I think in reality, like you mentioned, it can take a considerable amount of time, if at all, right? No, I think those are good points. You can go back to 13, Aebhric. So when you decide, like, how can you assist them? What are some ways to assist? The first thing that I would mention would be to like give them oxygen if you have it. Normally, we don't do that if we have an oxygen concentrator, or you can give them a brown paper bag and have them breathe into that to kind of get them to calm down, or give them oxygen through a mask or BVM, like, and assist them. Can anybody think of any other ways to assist somebody in controlling their respirations?
Good old positioning.
Positioning, yes.
Yeah, actually, a number of times I just coach people to breathe deeply their nose and slowly out their mouth. And that seems to have worked. But it requires time to sit there calmly with them to do that.
I agree. You can almost you can get them to do some breath holds to recruitment maneuvers. Taking a deep breath and hold it. I think one of the things that happens in training that I end up correcting is, we think, oh, I just hold it for 3 or 5 seconds. I don't think you should give them a time reference. I would just say, all right, you and I are going to take a deep breath and we're going to hold it as long as we can and just see what they're capable. And then, have them kind of demonstrate their ability to hold a breath. And if it's not very long, then you can encourage them to maybe do it a little longer. Or if they physiologically can't, that gives you an assessment of where they are physiologically. You just take a deep breath and hold it, and then see how long before they have to exhale or take another breath.
Sometimes if you have the luxury, I like to explain to them what numbers I want on my end tidal. So I put them in front of the monitor and I say, hey, this is our range. Try and get within there. And sometimes if they're mentating appropriately, they'll be able to do that.
No, I think a lot of the people we work with or the patients we treat, if they're colleagues, they're very competitive. So you give them a number to shoot for. Yeah, that's a great technique. I like it. Hey, I'm going to put this pulse ox on you, and I want you to keep this number, above 90. That's a good way to do that. I like it. So when you treat, we talked about you decide that you need to intervene on this patient. Positioning is one of those. What are some of the positions that you would put them in?
Ask them what's comfortable. They can generally have the ability to find that position themselves.
Yes.
Maybe it's as simple as, hey, can you sit up? Can I support you on a bag? Get them to that 40-ish degrees.
No, I like it. If you leave them alone, they're most likely to find that position of comfort, and most likely that's going to be a beneficial position. If they can't sit up or if they have other concomitant injuries, then they're going to get in the lateral decubitus. But yeah, they'll figure it out. No, that's a good. You could also watch your intervention. They'll start going from a laid back position to a tripod position based on physiology. They're going to find a position that's more comfortable. If they're uncomfortable, they're going to keep moving around. So the fidgeting itself is going to be an indication that there's some kind of disruption going on. And then where they find stillness is going to be that position of comfort. And that position can give you some indication of what's going on physiologically, right? If they get lightheaded, they're going to want to lay down. If they have difficulty breathing, they're going to start sitting up. They're going to position themselves forward if they've got secretions. So, those are things that you can observe that they will naturally do. So what is your indication for, we'll just do this in order. So needle chest decompressions. Are you doing more anterior or lateral? What's your training telling you to do?
We're supposed to do more lateral, but I honestly feel more comfortable finding the location of anterior. Also, just like more room.
Okay. Are you treating more military or trauma victims, or are you treating more civilians?
Well, there's civilians that have been shot up.
Okay. Okay. I know in the TC3 guidelines, the way they phrase it, I don't like it. They phrase it as don't go medial to the nipple when you're doing the anterior approach. It when I have all my spare time, I try to golf. If I go up to the tee box and I say don't slice, I end up slicing the ball more. Don't hit it into the water. I hit it into the water. So I would phrase it more positively, and I would say, put the needle lateral to the nipple, give the positive indication. If you're teaching this, I would switch the wording to say, do the insert the needle lateral to the nipple, don't avoid telling them don't do something. Because if they lose that negative aspect of the comment, they remember medial to the nipple, and they kind of miss in their stress the negation of that. So I would say insert the needle lateral to the nipple line if you're doing anterior approach. They don't add it, but I would say don't stick anything in the chest inferior to the nipple line either. My understanding of the anatomy after doing as much ultrasound as I have is the diaphragm is significantly higher than I was taught. I used the bottom of the ribs as where the diaphragm was because that's where all the anatomy books put it. And it couldn't be further from the truth. It is essentially at the inferior mammary line. So it's you got the nipple level and then that rib underneath, that inframammary fold on females and some males. But basically, if you don't stick anything in the chest, if you stick everything in the chest lateral to the nipple and above the nipple, you're going to be successful more often than not. Does that make sense? I think giving the positive aspect of that, putting the needle in. Now, what is the standard way you're taught? You can progress from needle to a finger thoracostomy to a tube thoracostomy. What are your protocols for? Do you just advance to a chest tube if you had it, or do you do the needle D, or do you do the finger first? Like, what's your preference based on the scenario?
In Ukraine, we would prefer the finger thoracostomy.
Okay, and I agree with you, but why would you say that?
So we made some tests with a pig lung and we put a plastic bag around, and then we just tried the needle decompression, and it was not really effective. And we said, okay, when we have the almost good environment in our ambulance, we would prefer this as the first treatment, and afterwards would be like a normal chest drain.
Okay, so let me see if I heard you correctly. You were having lack of success, or you were having failures with just doing the needle D?
And we had a lack of success.
Lack of success. Okay. Okay.
I think it all depends on the patient. If the patient is awake, I'll go for needle. If not, if I need to do a finger thoracostomy, I need to intubate him because of the negative pressure, or else need to do a chest seal, and they're going to make it worse. However, I'm always concerned about the hemothorax. If the patient's got a hemopneumothorax and the blood is concealed inside the lung, if I make a finger thoracostomy, I may solve the B problem, but then I get a C problem. And if I don't have blood, it can be an issue.
Okay. No, that's reasonable.
I just have a question to that. So you mean that the patient is bleeding because of the finger thoracostomy? Because as I understand, if there's like blood already in the wrong space, it's just like affects the breathing, but it's not already, so it's out of the circulation system, isn't it?
No, what I was trying to say is if the patient's got hemopneumothorax, so as you know, the lungs are fully irrigated from blood, and sometimes it's not just air inside of the intercostal space. It's sorry, the pleural space. It's sometimes it's blood. If the blood comes out, and we end up having a C problem. Sometimes they came up with 3 liters of blood straight away. They're bleeding a lot, and now we need to control it. And without the clamshell, I don't know how we'll do it.
Are you
Yeah, I got you.
progressing after the finger thoracostomy? Are you progressing to a chest tube based on the findings, whether it's a hemo, pneumo, or just a hemo?
Sorry, say again?
Are you finding yourself progressing from a finger thoracostomy to a tube thoracostomy or chest tube based on whether it's a hemothorax or just a hemo-pneumo?
If you have a chest tube, it'll be great because of the reservoir, if I have one. The problem is I don't have one, it can be an issue. But of course, finger thoracostomy is better than the needle because it's bigger. But of course, I need to sedate the patient because they're going to cause positive ventilation. And if it's negative ventilation, the patient it's breathing on his own. It's going to make it's not going to make what I want. If I have a chest drain and a container, great. In order to make the vacuum, great. But again, I'm always concerned about the bleeding inside the chest. If I have a pneumothorax chest, it's easy. If I have a hemopneumothorax or hemothorax, things can go a little bit more complicated because it's blood coming out. I have no way to control it.
Okay, that makes sense. My
Wait,
screen.
can I ask real quick? Alfredo, were you saying that before you do finger thoracostomies, you prefer to sedate and intubate? Or are you okay with just leaving them?
So what I understand is if the patient is breathing is negative pressure, right? Physiologically, it's negative pressure. If the patient is breathing on his own, right? If I do a finger thoracostomy, I'm gonna make an open pneumothorax. So it's a bigger hole, but the air goes in. So the effect, the what I want, it loses. So I need to sedate in order to ventilate the patient positively, in order to the effect to correct the pneumothorax, the air inside of the pleuritic, the area to come out. So at least it's my understanding. It's not normally happens. So normally, if I do a finger thoracostomy, I need to sedate the patient. But please tell me otherwise. If you have a situation you've been doing finger thoracostomy without it, please let me know. I would like to hear it.
So do you put a chest seal over your finger thoracostomy?
If the patient is awake, breathing on his own, right? Breathing on his own, I have to. So I need to do a finger thoracostomy, right? But if patient is doing negative pressure, right? I need to put a chest seal, or else the valve. You need to have a valve to prevent the air from outside to go in.
But that doesn't mean that you have to sedate them and put an airway in to go from negative pressure breathing to positive pressure breathing.
No, I can do BVM, but based on that, the patient needs to tolerate the positive pressure I'm doing with the BVM, and normally with pain and so forth, they normally don't. So I'd rather sedate them and tube them in order to do it.
Okay. Are you in a situation or a clinical situation where you have all the meds to do that, to sedate them for an intubation? Do you have ventilators?
RSI, depending the area where I am, right? Of course, if I'm working in UK, just needle decompression. If I'm offshore or if I'm doing helicopter race too, yes, I can RSI and intubate and ventilate the patient accordingly. With the finger thoracostomy, of course, if you're going to fly the patient doing the pressure, by default are supposed to do it anyway, to prevent things get worse. But yeah, I'll do it.
Okay. Do you do crikes at all, or is it just right to intubation?
Crike, again, if being in an austere environment, I need to have enough drugs to keep him sedated for a long period of time, right? My current class, if I have enough rock, normally rock is just initial intubation. I need normally I have or ketamine or midazolam if the blood pressure is low, will be ketamine, and the patient will be able to hold the ketamine and then keep sedated as for a few hours at least to be evacuated. Normally is how I presume ketamine just. Of course, it's fentanyl for obvious reasons, for the patient to tolerate the tube, no pain and so forth, but normally it's ketamine. And if ketamine and fentanyl, again, depending on the blood pressure.
Lasse, you had a question first.
Yes, so just a general question. If I come to this, or if I go to this point that I say, okay, we have to make a finger thoracostomy, do I really have the time to RSI my patient? Because mostly we're in limited environments, and I'm on my own or just with my team partner, so it takes some time to do that.
I think as an individual provider, you have to decide if it's in your scope of practice to do both of those. Then you have to decide which one is logistically the best option, and then you should have a pace plan. What's your primary plan? What happens if that fails? What happens if that fails? And so, even if I plan to intubate somebody, in my backup plan, if I have trouble, is to crike that patient, and that stuff needs to be laid out and ready to go depending on the scenario. So I think it depends on the situation. It depends on your preparation. It depends on your supplies and personnel. So it's a very dynamic question that's going to be answered basically by your situation, training, and staffing. So there's not one simple answer. You know, if you're capable of doing all, then you need to come up with a plan to run through your sequence. Tanga, you had a question?
Yeah, can we please have a little chat about how common it is that when you sedate your patient, they just die? It's, you know, it's sort of going back a little bit from earlier. When you were talking about the patient fidgeting and moving and being uncomfortable, I just, kept having flashbacks of putting patients on, trying to get them on CPAP, and they're getting uncomfortable. And, your really main option is continuing that positive pressure, trying to improve their respirations, but you can just see that they're spiraling, So, in our protocols, we have some light, I guess you could call it sedation / anxiolysis, but we use midazolam, and I have just found continuous, over and over, that there's two ways this goes. Either it works fantastic or they just crump. And I could sort of see the same thing going on with the conversation we're having right now. If my patient is barely able to tolerate, breathing on their own, they've only got one lung working, I'm going to focus on that finger thoracostomy so that we can get something going up. But I'm, it sucks in terms of pain management. We can give as much as fentanyl or whatever as we can, but I just can't see how sedating this patient at this time isn't going to lead to downstream effects.
But I definitely want other people to chime in on this, but I would say that all of this is an experience and a gestalt kind of feeling too. You have to look at the mechanism and what else can be going on, concomitant injuries, which in the fourth category here, manage. That's why resuscitate's on there, because a lot of times if you're going to do a procedure, if you're going to sedate somebody and they're already in significant shock, then that may be the factor in determining you crike somebody versus RSI because of the medications that are involved. So all of that is an equation that's 4D chess, if you will, trying to figure out what's your appropriate management. Your question that you asked in the beginning is, how many people basically die the minute you sedate them? That's, I'd have to do a lit search to see. It happens way more than it should, and that it shouldn't ever happen. But I think sometimes you can do everything right and the patient still does not do well. So any other comments about the resuscitation aspect of RSI?
I have one. What I've been told I've been doing, and it's quite successful, is resuscitate before intubate. So oxygenate properly. I normally give 30 liters of oxygen per minute, 15 with a nasal and another 15 with BVM. Normally the stats go up quite quickly, and leave the nasal cannula on 15 liters. It's uncomfortable for the patient. The patient is still awake, but it will do the job. And then fluid / vasopressors before give him the ketamine and then the rock. Why? Because the patient had a minimum of blood pressure high enough to be able to tolerate the drugs. If I give him ketamine and then rock on him, the patient's going to crash, he's going to die in front of me. So initially, flush, just 250 of fluids if I don't have blood. Ideally, it will be blood. And then epi normally push dose, diluted, of course, one in 100,000, or phenylephrine if you have available, and in order to increase the blood pressure, and then give them ketamine and then rock, and the patient will stop breathing and I'll put the tube in. At least that's how I do it. About the tension pneumothorax, first approach would be needle in order to gain time. If the needle doesn't work while I'm doing it, I'll probably go and escalate for finger thoracostomy. But the issue is if I'm going to make a hole, it's going to create an open pneumothorax, and I need to put the chest seal. And then depending on the chest seal, it may not work. So it's a catch-21. At least that's my opinion. Thank you.
Thank you. Had a question?
So that makes a lot of sense, Alfredo. I think I was sort of backing up a little bit and thinking more, my patient, I'm sure we've all seen this, that hypoxic drive is, when you get sort of that cracked style strength, and that's all you're thinking about, and all they want to do is rip everything off and working against you. So I'm just thinking about strategies and seeing if anyone else has any better methods, because really the only thing I've been able to do is go for sedation, IM sedation, and then you're really just playing a catch-up game, because you can't do any preemptive resuscitation before you sort of, let's say in quotation marks, intubate, because all I really want to do is get some bagging in to start, because your patient is just fighting so much. So I'm just wondering if you guys have had any success with those hypoxic fighters, and how you address that.
Go ahead, Alfredo.
I've got one. It's a little bit controversial. I learned this in UK dealing with end-of-life patients. As I said, it's controversial, but it works and sometimes does wonders. If you give a little bit of morphine or an opiate, at the time I was giving diamorphine and midazolam IM or subcutaneous, in order for the patient just to cool down and kill the hypoxic drive, the patient's going to start breathing better, because that's that sensation that the patient has of hypoxia. Every time, you can imagine if you're diving, right, that effort to come to the surface, the patient is panicking. If you give them that, the patient start having deep breaths, increase the tidal volume, and actually the starts getting better. And because the patient is calm, now you'll be able to deal with them better. However, in terms of the guidelines, giving opioids and benzos to a patient with respiratory failure is a no-no, so we can get into trouble. But it works, at least is my opinion. But don't do it depending on the guidelines that you're working, because you can get into trouble.
Lasse, you had a comment?
Yeah, so I can just say the German guidelines for paramedics says, especially for patients with pulmonary edema, or also like this anxious patient on CPAP, we are normally giving them around 2 milligrams of morphine IV. And this normally works very well to like calm them a little bit down, or just like I can't really describe it. It's more like helping them to like focus on the respiratory part.
Mm-hmm. I think if
Really
pain is the driving factor, morphine, I used morphine back before they took it out of the system. And what I found is that the delayed onset effect of giving the morphine caused you to give more of it. And then when it kicked in, it actually surpassed the amount of pain. So if I were just giving morphine to somebody and effectively treating their pain, I never had any respiratory issues. It's only when the morphine exceeded their pain, took away all their pain, that it started actually dropping their respiratory drive, in my experience. So you develop a good ear of when and how much to give. And part of it is being patient for it to kick in, morphine wise. So 2 milligrams of morphine IV, if you're monitoring your patient, is generally going to be enough to control their pain without killing their respiratory drive. That's my experience with that medicine. So that kind of matches up with what you were saying.
Exactly, and it's more like it calms them down a little bit. So this was like the most experience I got with this.
Les or Kelly.
Yeah, one of the things, just listen to the way that Fredo explains that, one of the things that we talk about in our system, when you've got that patient that's fighting that, whether it's hypoxic drive or whatever it is, using either pain relief in the form of an opioid or a benzo, usually midazolam, going with a half dose, and using that to gain access to the patient so we can assess the patient at that point, because somebody who's in that big a panic, they're totally inaccessible, and it's extremely difficult to do any type of rational assessment.
You're treating more anxiety and fear versus pain.
Yeah, once you get over that, you get them, as it's been said, once you get them to slow down, you can gain access to them and maybe start getting some answers or getting some indications as to where injuries are, and kind of a little bit clearer picture of what actually is going on.
Yeah, no, part of it is you being calm and being able to convey that to the patient, but recognizing that you need to treat the anxiety more so than the pain, and giving just a touch. That's experience. That's good to share.
So are you guys saying you're giving IM opiates and that you're having that success without having like a drastic note in like dropping blood pressures during, because obviously we're not able to do the full assessment of these people because they're actively fighting you. We're talking about proper hypoxic like fighting. So you guys are just saying you go and you give an IM opiate and you're getting that reduction in the fighting before you get a marked decrease in blood pressure.
So what I've done is not necessarily the opiate. I'm not going to go directly to that. I might go with 2.5 of IM midazolam, just to take the edge off of things and give me a little bit better ability to assess the patient at that point. And
right,
I haven't had any problems with it. Okay, so you haven't had any problems with it. It's interesting because we do the same thing, and that's when I've just seen people crash because of midazolam's effect on the blood pressure. So, okay, Lasso, were you saying, and Alfredo, were you saying IM?
Yes, I had interesting results with patients, again, with end of life, giving IM, at the time was diamorph, but morphine will work just fine, and midazolam, that tiny amounts, slow absorption, and they will come down and we'll be able to deal with them properly. Again, that's my experience. And honestly, I thought the first time I gave that, I said, I'm going to kill the patient. The patient's going to die here from me. But because it was end of life, and I was allowed to do it, and the guidelines said I should, I did it, and guess what? SATs came up, and the patient started talking to me. And I was amazed. And almost because of the tidal volume. The patient decreased the respiratory rate, increased the tidal volume, increased oxygenation, and because he killed that hypoxic drive, it was great.
Exactly. So we use it IM for end of life patients. To be honest, I never came in this situation where where the patient had so much anxiety that I was not able to cannulate him for an IV access. but I'm pretty sure this works as well. So to give IM morphine first. But yeah, normally I would prefer to have an IV and give him like around 2 milligrams, and that's it, not more.
That's fair. I think it's a good plan to give lower doses, and you can always add. It's just you can't take it away. You reverse, but now the patients you were talking about that you gave the medicines, what were their other mechanisms? Was it that? How much resuscitation did they need before? What were the mechanisms in the cases that you said they passed?
I think the times I've seen this most on is you get on scene, it's an opiate overdose, and your patient has aspirated, and that's the concern. It's not necessarily the opiate overdose. It's just the fact that now you're already hypoxic, you're already hypercarbic, and then they aspirate. And that's when things just go downhill, because once you give, the fire department's already given that Narcan dose, so their mentation's improving to the point where they're not like, to the point of being somnolent, but they're noticing how hypoxic they are, how hypercarbic they are, and it's really, they're literally, it's just like when someone's drowning, that's all they're doing is they're fighting to get air into themselves, and there's nothing you can do other than sedate, and that's what our protocol is to sedate them with 5 of Midaz, and just like you just see them go either absolutely no reaction, and then the second dose you give, they're just flat on their back, and you're trying to do a catch-up game. So I'm really interested about the opiate use in that respect. But if it is post Narcan, then you've got the situations. But
I think you're exceeding the ability of Narcan to reverse, and so interesting. Any other? I did a great discussion. I love the back and forth on this. This was good. Any other comments that we need to? Any other questions? We're at 48 minutes. Cool. Well, Aebhric,
I'd actually like to ask one, and this is something that I've never really run into the problem. But in our system, it's a common discussion, is at what point with tachypnea do you start trying to ventilate somebody? My concern is always that there's something that's driving that tachypnea, typically hypercarbia, or they're trying to adjust their acid base, or trying to blow off acid, and I kind of feel like, unless this is without sedating somebody, just at what point should I be thinking, maybe I should start breathing for them? And I don't have a good feel for that.
Okay. So if they're tachypnic and their vitals and their numbers, their sats are still not up, is it a lung issue? It's not a breathing issue. Is it a lung issue? Is there an effusion going on? Is there a pneumonia going on? Is there an empyema? Is there a lung issue? Is physiological, trying to oversee a metabolic issue that they're trying to acid base correct? I think you need to take in the whole picture of what's going on based on it. In the setting of trauma, that's one thing. It's the setting of hospice, that's another, right? Any comments from the group?
Yeah, I have one. Few that I come across, especially DKA, when they're in Kussmaul breathing, if they're 40s, they're not ventilating per se. So the tidal wall is quite low, and the breathing is through the roof, the 40s to 50s. So they're not oxygenating. The idea is to give them something to take over, right? I'm not saying 2 RSI straight away, but at least some benzo or opioid, something for you to take over, but keep the rate initially as it was. So if it was 35, 40, and then slowly start to come up, because if you cut it straight away from 40 to 12, they're probably going to arrest. At least that's experience that I have. But please, by all means.
I think the body doesn't like to do anything rapidly, so going from a rate of 35 to 12 is going to cause its own complications. I didn't think of the DKA, so that's another reason. How much is on anxiety? Would you want to give an anxiolytic to get them to calm down and to decrease the rate, increase their tidal volume? When would I take their airway?
Is this because they're hypoxic as well, guys, or are you just concerned about how fast they're breathing?
I think it started, correct me, Kelly, I think it started with the tachypnea and hypoxia.
Yeah, one of the things that we're doing is I teach EMTs and paramedics, and one of the pieces, it's like, oh, if they're above a certain number, then we should be bagging them, and for me it's just, wait, there's just too many things to go into that. And I think about the idea of somebody who has metabolic acidosis that they're trying to use respiratory system to get rid of. If I'm taking over and I'm breathing 10 times a minute for them, I'm gonna mess them up. Sorry, somebody just walked up to the house. The dog's freaking.
I don't know. I didn't hear everything of that, Kelly, but I've started having a transition in my own practice of initially, when I was in EMT, they say over 35, over 20, you start bagging, you start trying to bag them down. And I don't think I've ever had proper success with getting someone's respiratory rate down by bagging them down, like genuinely. I mean, if what they're needing is more PEEP, then the CPAP will do that, but not just like forcing them down by bagging. So the more I'm understanding about the hypercarbia issue, if they're satting well, or if they just need a non-rebreather, then I've just been leaving them on that and just letting their body do what they're doing.
Kind of giving them some guardrails.
Yeah, I mean, I just realized that I can't match the respiratory rate they're getting at, and if they're not hypoxic, there's really nothing much sort of pointing me towards fixing it, unless it's obviously, we've got a tension or XYZ. But if we're just thinking it's an acidosis issue, then I've just been trying to sit on my hands, like we were talking about earlier, and just let them do their thing, because I can't really do much. Like, my options are either leave them on a non-rebreather and they're satting well, super tachypnic, but we're satting okay. Or I try and force them down, start bagging. It probably doesn't work. I end up sedating them, and then I have to deal with the balance of all the other things involved.
I just thought about taking the mask and then putting a PEEP valve and turning it to 10 or 15 and just having them put that over their face and try to breathe out through that to slow it down just a little bit, give them somewhat resistance. I don't know how fast that would increase the recruitment, but
I love that. I stole that from the DSI video that we had in one of the classes a while back, and that's been working really well. Everyone looks at you like you're a bloody idiot when you walk into the hospital and you're not bagging the patient, but it does really make a difference for them, because the CPAP sometimes is just way too much. They hate that, but just that little bit of PEEP is enough.
Yeah, just to slow them down. It's an obstacle, and that in the process just slows them down just a touch. Maybe just enough to get them more oxygenated so they're not fighting that.
That's a really cool idea. I like that one.
I know it's good to do in a class where you're teaching bagging techniques, to have the students lay down and actually have one person bag another. It's a great learning environment to be the patient, to understand where those leaks are going to occur in the mask for trying to get a good seal on the BVM, and the effort it takes to breathe against PEEP. It's a concept that I didn't learn as a medic. It wasn't, till I started teaching stuff and working with a respiratory therapist that was, an expert at this, picking up good techniques. But yeah, breathing against that PEEP as a student really gives me a perspective that I just never had as a provider, Cool. Any other questions or comments? This was a great conversation. I definitely, Aebhric, I like this format much better. So